looking forward to that. And with that, I am going to turn over to Val, and thank you, welcome, and enjoy the conversation.
Thank you, Paul. Very happy to be here. And I would like to thank Phoebe and Paul and the BC Rural Health Network for providing the BCatch team and two of our Community Health Centre executives with the opportunity to talk about the Community Health Centre model with you all today. We're very, very much appreciative of this opportunity. I'm the executive director of the BC Association of Community Health Centres, and as Paul has indicated, we call ourselves BCatch because it's a lot easier. I'm joined today also by our operations director, Catherine Au. If you could, give a wave, Catherine, and also our admin research and project coordinator, Lisa Eccleston, who is running the slide deck for us. In addition, we have the CEO of the STEPS Community Health Center, and that's Christine Matuszewski. She'll be presenting later this afternoon. And we also are joined by the executive director of Umbrella Multicultural Health Co-op, and that is Zarguna Vakil, and also one of her team members, a cultural health broker, Kautimak Resendes Fuentes, and I hope that I have said that appropriately well. And we'll be introducing all of these folks later when it's their turn to present. And so on to the next slide, if we could, Lisa, and I'll talk a little bit about what a community health center or a CHC is. So by definition, we use 5 criteria to indicate a community health center. And these 5 criteria are also used in policy by our BC Provincial Ministry of Health. So in order to be considered a community health center, a site has to have team-based interdisciplinary primary health care. There has to be an integration of services, so going beyond the delivery of primary care, but also promoting health, the social determinants of health, and general community well-being as aspects of care delivery under a CHC center. A center is also community governed, which means we're dealing with a not-for-profit or a cooperative organization that has a board of directors who are representatives of community and support the service delivery and design at a community health center. We have a couple of principles that CHCs adhere to and focus on, and that is the fact that the team actively addresses the social determinants of health. So those are things like food security and safe water and housing supply, and also demonstrates that commitment to health equity and social justice, which means that the community health center and the team providing the care focus very much on the needs of the most vulnerable in our populations, as well as our geographic population. So that's what a CHC is by definition. And the next slide, Lisa, will give you a sense of some of the history of CHCs in our province. So we have a 50-year history, 50 years of history of having CHCs in our province. Some of the oldest locations are the Reach Community Health Center in Vancouver, the Kool-Aid Community Health Center in Victoria, and the Mid-Main Center in Burnaby, not to only list a few of the oldest. We've got CHCs who are in both urban and rural settings, and they serve a range of population in their location. So very often a CHC will be created and designed to offer specialized services to a particular vulnerable population, or they will design services for their full geography, or they will combine services to serve both the vulnerable population and the folks in their geography. So each of the CHC models are different. And we say when you've seen one CHC, you have seen one CHC, because each is different and they serve the needs of their particular community, which allows them to be very heterogeneous in terms of service model. And when Christine and Zarguna and their teams talk to you today, you'll get a sense of the differences that the service design has allow them to provide for their community. The community governance, as I have mentioned before, is designing care for community and governing it by community. And so that's a difference in the model, and offering a broad range of programming that support both health promotion and the social determinants of health is a key differentiator with the CHC model in communities. And as at our last count, our CHCs have indicated that they are serving over 200,000 folks a year across all of their different services and across all of their communities in our province. Next slide, Lisa. Thank you for the applause there. I appreciate the clapping. To give you a sense of where our CHCs are across the province, this slide gives you by health region some names of some of the community health centers that exist in the health region. This is only a partial list of community health centers. We have 34 operational at this point in the province, with of 45 communities that we're working on in total to support the development and implementation of CHCs. And so if you see a name of a community health center that you recognize in a region, that's terrific. And if you don't, we certainly have more information about all these CHCs on our website or through conversations with us. And if you see a name of a community health center that has a small e in brackets after its name, then you will know that that little e means that that particular health center is an emerging health center. So we're working with the community of that health center to help them to develop a CHC. So they're emerging and they're not offering services at this point. So we've got a lot of activity across the province with the CHC model. Lisa, next slide. Thank you. All righty. So this slide just gives you a brief snapshot of 3 of our community health centers, 2 of which you will be speaking with today. But it gives you the sense that each CHC is different based on the kinds of services that their community needs. So Kool-Aid, you can see the types of services that they are offering to their community here in Victoria, and also a snapshot of the practitioners that they work with in their team-based care model. You can see what Umbrella does, and you can see what the Steps and Sun Peaks folks do in their regions. But I'm not going to steal the thunder of the presenters that come later, because they'll certainly go into detail in terms of their care model and their team and their team-based care. And with no further ado in regards to that, I think the next slide is introducing the Umbrella Multicultural Cooperative. And our presenter there is Kautimak Resendez Fuentes. And I want to make sure that you are with us.
Kautimak.
Excellent. I'm going to turn it over to you. So please go ahead.
Okay, sounds good. Okay, give me 1 second. Hi, everyone. Well, my name is Cuauhtemoc. I'm originally from Mexico, but I have been living in Vancouver for the last 5 years. I work in Umbrella Multicultural Health Cooperative. An important thing about Umbrella is that our board of directors, the 80%, are members from the communities we serve. So that's very inclusive, and I think that makes us kind of unique. If you can change the slide, please. So I will talk about who we are, where we are located. We are located in New Westminster, BC. These presentations will have like 2 main parts. The first one, I will talk about the family practice. And the second one, I will talk about the mobile clinic, is where I work as a CCHB. I want to make just one question. Is everybody familiar what is a cultural broker?
No.
Or I can just move in. Well, I will bring a small definition just to start. A cultural broker is not just an interpreter. Is a person who understands and incorporate different cultural approaches Usually these persons are member trusted from the communities that they serve, and they understand multiple diverse perspective of medical, social, and well, all the social determinants of health, and help to the newcomers to face all the challenges they have because their culture, language barrier, or some other things. So that is a cross-cultural health broker. So can you pass the next one, please? As I said, well, can you pass? I already explained this. So here is what I said. I will talk about the family practice. So we are like, our patients are refugees, newcomers, or anyone that identifies with a cultural or language barrier that need access to the health system. So is what we do in the family practice. Can you change the slide, please? So in the family practice, we have in-house counseling. That is very important because we detect that most of our patients need support with mental health. The other thing that we do in-house is like we have a program that help them to address all the problems or layers that they have that they face with social determinants of health. There is another part of our team of the family practice that do health promotion. They do sessions, sometimes in line, most in person, about diet, healthy way of life, how to cook, everything that makes their life easier and healthier. And then is the program where I work, the mobile clinic. Can you change slide, please? So the mobile clinic started in 2011, and our target population is to serve the Latin American farm workers that come to BC every year. Can you change the slide, please? So our patients are all of them Spanish speaking patients that come from usually from Mexico and Guatemala, 90% of them. Every year they come like between 6,000 to 10,000 to work in the fields in BC. That is very important. So think about this. Every time that you eat an apple or an orange, think that maybe, and the possibilities are really high that a farm worker was the one that harvests that for you. So we serve this population, but this population has some issues. Usually they come with some health issues like chronic disease, like diabetes, hypertension. Sometimes because their work is very physical demanding, they have problems related to work, like because repetitive movement, they get injured. So we address that also. And another thing that we detect, they need support with mental and sexual health concerns. Can you change the slide, please? So after years of practice, not of me, of the mobile clinic, we found these are the most common barriers that this population faces. The first one is the language of barriers. So they usually speak Spanish and they don't know how to talk or communicate in English. Some of them don't even speak Spanish, speak their own language. So from their small nation or from their town, village. So this is very important. So they cannot communicate. The second one is system navigation. So they don't know how the health system works in Canada, especially in BC. Most of the health system is in English. So they don't speak the language and they don't know how to navigate it. The other thing is usually farms, not all of them, but most of them are in rural areas. So to get access to a medical, to a clinic, labs, or hospital is very far from there. Sometimes they have to walk like 2 hours just to get to his appointment. But then remember when they arrive to their appointment, the doctor says, "Oh, I only speak in English," or the MOA say, "Oh, I only speak in English," and you're like, "What?" So this is very important. Um, Also, they have a scheduling conflict. What does it mean? This population works usually 6 days per week. shifts from 10 hours to 12 hours. So it's very hard for them to find a space to go to the clinic. And as we talk, they face the other layers that we already talk. So, and sometimes they face like stigma and discrimination because their color, because their country background, or because they don't speak the language. These are the most common discrimination that they face. And another thing that we detect is that because they do very physical, high demanding jobs, they sometimes it's very common that they get injured, but they don't say to his employer until the pain is very high. Why? Because they are afraid to lose their job, because they say, oh, if I go to the doctor, my employer will say, oh my god, you cannot work with me anymore because you are helpless, or I will send you back home. And you know what, that is true. That is true. Some farms, when they get injured, they say, I cannot deal with this, go home. And they gave only 2 days notice. So these are the barriers that usually this population faces. Can you change, please? So I already talked about the family practice. Now I'm talking what the mobile clinic do. These are the services that we offer. So we go in person, sometimes to the farm. For example, during COVID, we provide COVID vaccines in some farms. Uh, Another thing that we do is during the week, we do telehealth clinical appointments. That is very helpful because they, during their break, during their lunch, mealtime, or sometimes at night in the evening, we still have, we run a clinic from 4 to 7:30. So it's a good space for them if they need a medical consult. Another thing that we provide is one-on-one support. Can you, yeah, you change it? Can you come back the slide, please? Yes, thank you. No, the next one. Yes, perfect. Thank you. So another thing is like every day, the CCHBs work with them, helping to address some challenges like going to labs, get a prescription, go to a consult with a specialist. So that is the daily basis of a cross-cultural health broker. Uh, Another thing that is very different from some other rural mobile clinics is that once we see a patient for just for one time, he's attached to our clinic. It's not that, oh, we go to a farm and they said, oh, provide some meds because he had a headache, and that's it. No, we follow up with them and they become a patient. So sometimes it's very hard for us to accept new patients because they are attached to our clinic and we become our family doctor, kind of. Another thing is that workers can access to our clinic independently. We don't talk to the employer. They don't need authorization, or we don't request anything. Sometimes they are struggling with their medical insurance, so we don't mind. We can accept them with MSP or private insurance, or if they are in between, also we can support them. Um, in the outreach activities, what we do sometimes for the important days of their cultural background, we celebrate with them sometimes Independence Day, Dia de los Muertos, Christmas, and we do these activities to get to bridge, to make connection with them, and to build a trust, because it's very important to build a trust as a cultural broker. You are, remember that I said I'm not just an interpreter, we are cultural brokers, so you have to link with them. Can you change it, please? So another thing that we do in the mobile clinic is we help them with the social determinants of health. We do warm referrals to other agencies. This is important, that it's not just a referral like, oh, this agency will help you. No, we are still in contact. We follow up with them. How is working? Is the person is helping you? Do you feel safe? Do you feel comfortable? Or we can look for another agency that supports you better. So this is how we do the warm referrals. Also, we support to navigate with the health social services if they need access to food bank, housing. It's not so common for this population, but sometimes it happens. As I said, we do activities in the field, like Dia de los Muertos. I love it because we eat a very delicious bread that is only made in that season. It's from Mexico. It's very good. Uh, and also, we support them with work safe claims. That is very common because sometimes it's very common that they get an accident in their work because they work with machines, or they usually are climbing ladders or physical activities. So it's very common for them. So we help in-house to support with work safe cases. And also we support with health promotion. Uh, when we do in-person clinics, we talk about diet, healthy lifestyle, chronic disease. Can you change the slide, please? This is our great team, and this is some events. Just to mention, our doctors are volunteers, so our nurse practitioners are volunteers. Can you change it, please? And for example, this picture is from a health fair that we went. It was a nurse, two nurses there. So they talk about, as I said, health promotion. They did BP readings and do some triage to accept new patients. So these are the things that usually we do when we go to a health fair. And sometimes when the space is comfortable and safety for our patients, we provide consults sometimes in the health fairs. So the mobile clinic is very effective to address the needs of this population, and we are looking to expand. We are often, if someone wants to open a mobile clinic and needs some advice or just to talk and see how they can develop their own program, we are open to do this, or to grow, or to get more grant, or just to collaborate with other organizations or with other communities, health centers, so we can address more population and we can go into the rural areas that we notice that is a high demand of to get to the medical services. Can you change slide, please? No? Does anybody has a question? That's it. Thank you. Can you change the slide? It's only say thanks.
I have a question. What's your favorite part about your work?
Oh, the social connection, the bridge that you make with the patient, and when the patient doesn't need you anymore, that's the best because they are empowered.
Thank you. Great presentation.
Thank
I
you.
had a question too about funding. You said that a lot of your health professionals are volunteers, but you must have core funding, and where is the source of that funding?
So we have different funding. We have grants and some funding from the Ministry of Health and also some agencies.
And the funding from the Ministry of Health, is that through the Community Health Clinics program? Is it recognized by the Ministry of Health as a community health clinic?
Yeah, it is. And Sarguna is here. I think she can answer much better.
I'll respond to that. Thank you, Kwao. Kwao was really passionate about his work as a cross-cultural health broker, as you may see. So the funding is coming from Ministry of Health as part of the Community Health Center funding. And then Mobile Clinic also has a stream of funding from ESDC coming through a network of organizations. About 26 organizations are part of that network. And a small portion of funding comes from that too. And we are really thankful to our volunteers who are really supporting the mobile clinic. As Kwao said, some of the patients are attached to our clinicians, but others are being seen by volunteer clinicians on the mobile clinic days as drop-ins.
EDSC, that's federal funding?
East DC, yes, the federal funding.
Federal, okay.
Does anybody has another question? That's it?
I can see a hand up. Phoebe, are you moderating or?
Yeah, absolutely. That's
Okay.
Donna there. Go ahead, Donna.
I think that the first thoughts that I had, what a wonderful idea for the seniors. Because if the seniors were able to have somebody come that could do exactly what you're doing, they'd be so happy and feel so loved and wanted. Because it's very difficult for them to get to the doctors. It's very difficult for them to understand what they're talking about. They're not quite understanding what they should be doing with exercising and with food and such. So I keep thinking, wow, what a great idea. Maybe we could get even a smaller van and just go to the senior centers. So whatever you're doing for them, we would love you to do for the seniors.
Umbrella is actually envisioning expanding the family practice to mobile clinic as well. For, as you said, for populations that cannot reach the clinic, for seniors, for people who have mobility issues, as well as people with like large families with small children. Usually parents cannot travel with all children with them. Well, thank you.
Well, that's it. Thank you. Nice to meet you, all of them.
All right. Thanks so much, Zarguna and Kao. Great presentation, and thanks for your questions from the audience. I am excited to introduce the CEO of the STEPS team. And I always say STEPS, but it has a real name, Supporting Team Excellence and Patient Society. We're joined by Christine Maniszewski to tell us a little bit more about her community health center model. Thanks, Christine.
Yeah, thanks, Val, and thanks, Zarguna, and your team member there. You guys are wonderful, doing wonderful work, and I had the pleasure to go down to Vancouver and see some of the community health centers, including Reach and Mid-Main and Umbrella, and each one of them is incredible, doing amazing things. If anybody ever gets the opportunity to stop by or see their space and talk with their teams, it is exceptional. It's very inspiring, and it speaks to the amazing work that is possible in BC. So yes, welcome. I'm Christine Maniszewski. I am a mom of two. I just turned 40. I have been working in this work for 6 or 7 years now. We started off with a $260,000 loan and a $20,000 grant, and we now care for over 14,000 people longitudinally. We have had multiple clinics. Right now we have 3 clinics in a mental health space. So I am excited to talk to you about some of the things that I've learned, some of the things about us, and the different models, and maybe some of the challenges, hopefully answer some questions, and help others develop and launch community health centers. So maybe we can move through the slides. I think my presentation will probably be a little bit faster, but I'm more than happy to stop and answer questions or have dialogue with people. Can we move ahead once? One more? Yeah, there we go. So STEPS was incorporated in April of 2017, and it was an idea that came to life by the doctors in our area. So the Thompson Region Division of Family Practice in 2012 received funding to create an incubator type business model. And so out of that came a multi-physician team-based care business plan that was really the cornerstone for the Sun Peaks municipality and for STEPS and Dr. Selena Laurie to incorporate and create 2 different community health centers. And that was kind of the evolution of the thinking behind this model of care in our area. So really, it was born by family doctors in our area, which is pretty grassroots and pretty cool on a regular basis. I think it's pretty incredible that there was so much planning and that we've gotten to where we are today. So again, we have 3 clinics. 2 are located in Kamloops, so kind of in the east area, in the Valley View area. We have our STEPS Orchards Walk Medical Clinic. Then downtown, almost right across from the hospital, actually, we have a smaller clinic called our STEPS True Care Health Center. And then we also had, we took over the operations of the Sun Peaks Health Center last April. And so that is where we're kind of located as far as physical space goes. We've got around 50 patient-facing people. So that includes family doctors, general practitioners. We've had nurse practitioners, allied health, social care providers, and we do all sorts of work. So STEPS was created also to innovate and share knowledge, enabling others around BC to implement and do what we're all doing in an informed, good way, and to be as successful as possible. Our board of directors is very interested and keen on seeing this model carried out across the province for anybody who wants to be cared in this model. And they really truly believe, and our team believes, that the community health center model is the best care model to receive quality patient care. Often I have these conversations around collaboration and sometimes I say collaboration is the death of productivity, but sometimes collaboration is the most important thing to get you to somewhere that you never would have gotten alone. And STEPS is that is a product of that journey of collaboration and diversity coming together and creating something that could never have been imagined in one person's mind or space or journey. So again, who makes up our team? We have family doctors, we have registered nurses, registered psychiatric nurse, we have mental health, a team of mental health people, so a registered psychiatric nurse, registered social worker, community health worker, registered clinical counselors. Trying to remember everybody. I've written it down here, so please feel free to refer to it. We also have a diabetic educator, a dietitian, a respiratory therapist that our team refers to and connects with regularly. And registered nurses within each of our clinics is really, really critical. In the administrative kind of world, we have a few different business or financial models that we are carrying out. And so we have a billing expert who helps us with the fee-for-service world. We have director of operations, we have a finance person, and we have a team of people who hold the framework so that all the people who are patient-facing can do what they're best at. And we remove all the barriers. We try to remove all the barriers to enable them to be as efficient and effective as possible. We also do a lot of training. So we have residents, we have medical students, we have had nurse practicing students, we have registered nurse students quite regularly, we have medical office students, and then we have other people who do bits and pieces of learning with our team quite regularly as well. Can we move forward? So what's the populations and that we care for and the impact? So the populations that we serve include the general population, longitudinally, as well as in urgent care. We provide women's and sexual health services. We support children, Indigenous people, and we provide urgent care. Those are the main populations that we've identified within our organization. STEP strives to provide urgent same-day appointments. So the majority of, well, pretty much all of our patients can pretty almost always access an urgent care appointment within 24 to 48 hours. In addition to that, longitudinal family practice, typically that is within 3 to 5 days that a patient can get an appointment for a regular booking. Occasionally, that depending on what is going on and people being sick and cold season, all the things, sometimes that's a little bit further out, but we maintain that urgent care access within 24 to 48 hours always. So even if the family doctor is booking further out, that patient still has urgent access to care if they need it. So we, between June 1st last year and May 31st, which is our fiscal year end, we cared for just under 60,000 people, provided patient visits, just under 60,000 patient visits, which is, it's a lot. It's a lot of care in a day, and it's pretty amazing. So there's some hard days and there's some better days for sure. We diverted about 3,380 ish patients from the emergency room with our urgent care program. So we're making a significant dent, I think, in the health system, and appropriately caring for primary care where primary care should be happening. There was a story of this young person who had toenail problems, so ingrown toenail problems, and they went to our urgent care doc, and he cut one out and said, okay, well, like, we'll see how this goes, and it grew back, and then the other one on the other foot grew back, and so he did his things, and then the person over the weekend was like, oh, well, I'll try going to the emergency department. And that 12-year-old said, I will never go to the emergency department again for my ingrown toenail. It took them an hour and a half, and they had to freeze my toe, and then they couldn't freeze my toe, and then they poked me in the wrong spot. And an hour and a half later, they did the same thing that our doctor did in 10 minutes without all the stabbing and the pain and all the things. So I am a true believer that community caring for community is just a wonderful way to receive care. And if it can be done outside of the hospital, there's all sorts of benefits. Patient care and outcomes likely being the biggest and most significant, but also the cost to the system. Yeah, next slide. So partners, and I think specifically this group was interested in our rural space. Is that yeah, somewhat right? So we have Sun Peaks Health Center, and Sun Peaks is about 45 minutes away from Kamloops. It is a very unique place in that it is the second or third largest resort town in BC, and it is a ski hill. And so during the busy months, mostly over Christmas, we see 20,000 people staying in Sun Peaks, and the annual population, the year-round population is 1,500. So we have a very, very interesting dynamic going up there. We have visitors, obviously, that have come from all over the world, as well as locally. Then we also have 450 young people, primarily between the ages of 18 and 22, all co-locating in staff housing, having a great time until they're not having a great time, which is typically January, when the blues and all the things and all the, substance use and things like that take their toll. And we have some really interesting, very interesting things. So definitely sexual health piece is a big piece of it. Mental health is a big component. Emergency, urgent type falls, bumps, concussions, broken things, heart attacks, everything that you could imagine walking into the emergency room typically walks through our doors. So it's a very interesting place, and I would think it's not dissimilar to most rural places. What makes it maybe a little bit unique is that year-round population, and then the surge of visitors during biking, and then again during ski season. Yeah, it's interesting. So we have about 1.6 FTE of longitudinal family practice, and then the rest is urgent care throughout the year. We have some really, really interesting partnerships that we've made at Sun Peaks between steps and Sun Peaks Mountain Resort Municipality. And Sun Peaks Mountain Resort Municipality and the Sun Peaks Health Association were actually the founders of the Community Health Center originally, using that business plan that I talked about earlier as the foundational document to carrying out and to operationalizing their work. And so lots of learnings, lots of reasons why they transitioned to us, but also they did an incredible job of setting the groundwork and very strong relationships in community. And that's a strength of a rural place for sure. That team right now cares for about 3,400 people longitudinally, and then again, urgent care visitors and employees of the resort. Can we move forward? Yeah. So that's steps kind of in a nutshell. When Val was talking about social justice and barriers, STEPS has had the unique opportunity of starting with the fee-for-service world. So we have not been a strategy funded community health center in BC up until very recently, with us being given the opportunity to operationalize a new clinic that we're just starting to operationalize. So it would be in the small E emerging category. other presentation, that particular clinic of ours. And so what we recognize very early is the fee-for-service model. If you can find, if you can scale and you can find efficiencies, you can support the care of people who face barriers within that fee-for-service model. So people who aren't able to show up to their appointments for a variety of reasons, people who take longer for those appointments. All of those people are actually marginalized, they face barriers, they're discharged. It's actually not feasible for a doctor to care for those people in large numbers because of the funding model. So again, what does this mean? Those people who are facing the biggest challenges often don't have access to care under our fee-for-service model in our province. And so that is why the CHC strategy and the government recognizing it and BCatch being part of the infrastructure and system design is so critical for our province, the people in our province to be healthy and well and to meet everybody's needs. Our system, collectively was designed for people who could access those people and follow the rules those people laid out. And unfortunately, we're in a place now where we're seeing we have to be as efficient and effective as possible. And that means caring for people broadly. And social justice is it's a big deal. It's a big deal for costs. It's a big deal for a community's wellness and health. And I think I'm probably preaching to the choir. So again, our step strategy is to diversify our funding models. One part will be the strategy funded part. Again, we have hit our economies of scale with our longitudinal family practice, LFP, MSP payment model. And we find that having over 4 FTEs of family docs working in that model, we end up breaking even and having a little bit of money to start addressing and putting that towards the social justice pieces, covering no-show fees, covering gas to get people places, taxis, providing food, getting housing sorted out. Again, we have a number of different professionals who specialize in that social justice space, and our team certainly does an incredible job of being efficient and effective and getting the right people doing the right work. So we overcome this, again, diversity in our strategy for funding, integrated teams, and then having a community-led board of directors. So our board is super, super nimble and responsive, and we have had to be that way because of the funding model. We don't have the luxury of not being nimble and figuring it out quickly, or we would go bankrupt. That's the honest truth of I think the fee-for-service model and community health centers. Oh, I see a hand, and I hear a bunch of things.
I have my hand up. Yeah. I just wondered, so your practitioners on fee-for-service, how about the funding for your infrastructure, the units in Sun Peaks and in Kamloops? Where does the funding come to maintain all that infrastructure?
Yeah, it's primarily so how we have designed it is again, that 4 FT of family doc time, that what we find is we can support all the infrastructure. So that's the rent, the medical supplies, the office supplies, the insurance, blah, blah, are very like the core longitudinal family practice if we have 4 or more FTEs. So we have grown, we have, I think, about 10 FTEs with 15 to 20 family doctors working in that model. And so that is how we get that space. And then for our allied health, we have received grants and we're working with the PCN to be supported in that way to continue providing that team-based care.
Okay, so how about the urgent care though? So the rents will support the urgent care facility as well?
So our urgent care docs fill in and work when our longitudinal family docs are not. Same space. So we have filled our spaces to the brim. We have through the pandemic with virtual care, we actually had like 7 FTEs working in a 4 FTE space. We're actually just starting to right size, but we do look at our spaces and we do minimize them, and we are as efficient and effective as we possibly can be with that, because if you're not looking at space from that perspective, it will be too expensive to run the service. Yeah.
Thank you.
I see another hand.
We have one more question from Paul.
Just to speak to one size not fitting all, how do you make sure that the STEPS program within Kamloops proper fits the bill for the Sun Peaks application in a very unique community setting?
So are you like, I'm not quite sure what you're asking. So we approach each family doctor and what they're doing and the population they're serving individually. So it's not a clinic level. We have a basic structure. So like a 1-to-1, one MOA to one doctor, FTE. We staff in that way. We look at the population that each of those people are caring for, and we staff up with a little bit more social work support if needed, or clinical counselor support, or we look at urgent care and the time and the space. It really isn't an individual MRP, so nurse practitioner and family doctor. That longitudinal practice is what we prioritize. And then we wrap all the supports around those individuals. So it's not different, I would say, for somebody working in Kamloops versus somebody working up at Sun Peaks. So their populations are just different, and we meet their needs to provide the most efficient and effective care. Does that make sense?
It does. I guess my question was more around, I guess, the governance model and within the CHC model itself, in having a board that represents the community itself and pushes the operation towards the community. How do you ensure that the voice of Sun Peaks is heard within your governance?
So we have a spot on the board that the municipality can allocate a person to sit on our board of directors. That has been an open invitation. They have some changes in their council right now going on, but the intention is and has always, and is part of our memorandum of understanding, that they're welcome to put somebody's name forward to be on our board. I also meet regularly with the CAO of the Sun Peaks Mountain Resort Municipality, and the mayor has my cell phone number. So I hear everything quite regularly and welcome that dialogue back and forth. Also, the team up at Sun Peaks is the majority of them live in Sun Peaks, and so they often know what's going on, and we work as a team to meet the needs of the community. Yeah, it's not easy. But I don't think it's easy in Kamloops either.
Nothing's easy.
Community health centers really aren't easy. It's not for the faint of heart. Somebody said to me, Christine, you must have really thick skin. That was this morning's comment, and I was like, I don't want to have thick skin. Anyways,
Rhinoceros hide.
it's tricky. It is tricky. Any other questions? Was this helpful?
Absolutely, yeah.
Thank you. Well, if anybody has any other questions, I'm happy to answer them. Or if you have questions in the future, feel free to send them to BCatch, and they know where I am. They also have my cell phone number.
Yes, absolutely. Not afraid to use it.
Yeah, feel free.
Awesome.
I'm happy to. Yeah. And very nice to see you all. Thank you very much for your support for community health centers across BC. Very much appreciated.
Thank you, Christine. I think we have, and there's Christine's contact info. Awesome. Okay. And so the last bit of our conversation today is a little bit about the BCatch organization. And so, oops, if somebody could mute there, that would be great. Okay, so I'm Val St. John. I'm back again on behalf of BCatch, as we call ourselves.
There we go. How's it going?
Oh, could somebody mute, please?
I think so, yeah.
Phoebe, any chance you could mute? There we go. Awesome. Okay, so yeah, so I'll just sort of wrap up by giving you a sense of some of the supports our association provides, as Christine was indicating. So our organization as an association was founded 6 years ago, if that's the math. No, 7 years ago, 2017, to support the development of community health centers across and around the province. Currently, we represent 45 actually community health centers or communities that are interested in developing a community health center. As I had indicated before, we have 34 CHCs that are operating in the province at this point, and we have another 9 coming on stream over the next 6 to 12 months. Our association supports members and communities in all stages of community health center development. And we provide education supports for CHCs, research, evaluation, QI, governance, consulting, engagement and advocacy. And when I talk about advocacy, I mean working with our provincial government to get support for the CHC model and to also provide funding, and we're working on the development of a core funding model, which is hard work, but we're very committed to doing so. Next slide, please, Lisa. Okay, so to give you a sense of some more specific things that we're up to right now, we're working with communities on how to develop a CHC. We have a CHC starter kit that we can guide communities through. We can talk about how to set up your board of directors and how to engage with the different agencies and associations in your community to build those collaborative partnerships for service design and delivery. We offer some operational supports. We're big into evaluation and research right now. So we're looking at the evaluation of different aspects of the CHC model so that we have the data that we need to work with funders to prove the value proposition of this particular service delivery model. We offer networking. So as Christine and Kao and Zarguna have exemplified today, our CHC members, they show up and they talk about the model and they share their knowledge and information and the work that they've done to develop and to get to where they are today. And so our networking is a really strong solution for communities who are looking to develop the CHC model in their own areas. We very often get grant money that we can allocate to community health centers, and we're thankful when the Ministry of Health provides us with the funding to be able to do that. We support the relationships with lots of different partner organizations, and that alphabet soup there on the slide is we work with the First Nations Health Authority, we work with Social Development and Poverty Reduction Ministry, the Ministry of Health, the Ministry of Mental Health and Addictions, Ministry of Housing, etc. So we reach out on a ongoing basis to make sure that not only do these various government agencies understand what the CHC model is, but hopefully they support the model and do some program funding. And of course, we have an education strategy to help that continuous learning around and with the teams in the CHCs. We're currently big into our advocacy role around the sustainable funding model, as you heard from Kao, Zarguna, and Christine. This work is not for the faint of heart because to start a CHC, very often you are cobbling funding together to get it operational until recognition comes under what is called strategy funding under the Ministry of Health for the operation of each individual CHC. And we're always looking to make sure that we have CHCs and community members sitting at the right tables to have the conversations that are needed regionally for healthcare service delivery design and decision making. So the PCN, or the primary care networks in each region, are key and critical relationships for communities to recognize and to be in decision making conversations. And we try to help to bridge those relationships and make sure that folks are getting to the right places for these kinds of important conversations when they're from community. And we're always interested in making sure that decision-making includes community health centers. So when government is developing its strategies, they're putting CHCs in the strategy for the kind of care delivery that communities in BC need. Last slide, I think, Lisa, if you would. Yeah, so developing a CHC for your community. If you're curious, you'll see our contact info at the end of the slide deck, but this is our day job. So Catherine, Lisa, and I, and our network of community health centers will work with your community to help you to determine your service gaps, your current assets, and your healthcare needs. And also, it's important that you identify your community partners, because collaboration and no duplication is really kind of important from a resourcing perspective in community. And as I say, we can work with you to discuss next steps and the kinds of supports that we can provide or that we can gather to work with each individual community who's interested in exploring the community health center model. Next slide. Yeah, so there's me and there's Catherine, contact info. And we're always happy to talk with any community or any agency that's curious about what a CHC might look like, and how to explore that further. So don't be shy, do reach out over time, and we'll work with you and give you a sense of what it might take. And I do believe that's the last slide. Oh, a thank you, of course. Thank you to our presenters. Thank you to the BC Rural Health Network. And thanks to you all for attending. And I see a hand. Susan.
Yes, I'm wondering, I live in James Bay, Victoria,
Mhm.
and we have the James Bay Urgent and Primary Care Center, which is totally underutilized. It started out with, I think, 4 nurse practitioners and 7 doctors, and not very long after it opened, all the nurse practitioners were gone, and there were 3 doctors remaining. And when I finally pried out of someone, I'm a attached patient there. And so I've gotten to know some of mainly the nurses. I'm a retired nurse myself. And I finally got someone to answer the question of what on earth happened. And very tactfully, someone said to me, it was a problem with the administrator. And once we got a new administrator, things improved quite remarkably, but there's still no nurse practitioners. It's totally underutilized. There's never a doctor there. The center is open from, I think, 8 a.m. until 8 p.m. There's never a doctor there past 4 in the afternoon, or not usually, and not on the weekends. And they have this system where they are supposedly taking walk-in patients, but there's never any space for them. So what I'm wondering is there any precedent for one of those UPCCs to be turned into a community health center? That's what I would like to do.
Okay, so the short answer is no, because UPCCs are health authority owned and operated. So
Yes, I know.
they're not community owned and operated. So you can't turn a UPCC into a not-for-profit organization because it's health authority owned.
Use their space. It's a great space and it's very well equipped. What would you take to get rid of them?
I think that is an interesting conversation to have with Island Health Authority about the services that you expect and possibly you're not receiving through that particular care model. I do know of a community health center that is developing that could possibly be supporting James Bay patients, and that is the Victoria Health Co-op on Pendergast. They're over the Starbucks on the 2nd floor.
Yes, I know,
Yeah.
but then you don't have, they're not able to do anything. Recently, I referred someone to them for, what do you call it, an assessment for home support. And they said they can't do that. Yeah.
No, that's not the space they're working in. So I can't help you with UPCC functionality, I'm afraid.
I don't think it's possible, but it's too bad because there's a lot of money that went into establishing that space, and it is so underutilized, and it could be so well used. I worked years and years ago at Hassle Free Clinic, which was one of the early community health centers. That was in Toronto. And And there was the Pine Street Clinic, and I think Vancouver had Pine Street Clinic and another one. Anyway, it's a fabulous model. It's a fabulous model, and it works so well. And these UPCCs don't work hardly at all.
Understood. I see Paul, and I thought I saw Larry previously.
We have Larry and we have Jane after Paul as well. So we'll go Paul, Larry, and then Jane.
Thank you, Phoebe.
So, Val, I know you know, and I just wanted everybody else to be aware that there's been a shift in positioning that I've seen happen lately. And, you know, me and Val are, I think, probably the only two people who watch estimates keenly. And there was Adrian Dix, who seemed to have an about face on seeing the CHC model as being the future for healthcare and primary care delivery in BC within some of his discussions at Estimates. And I'm wondering about, again, how you view the Ministry of Health's view now on community health centres. And again, I was in Victoria on Monday talking to Ted Pattison, and some of his concerns about, although supportive, his concerns are about attachment. And I wonder if you could speak to that a little bit.
Yeah, definitely, Paul. Thank you. Yeah, so, I mean, the Ministry of Health is very supportive of the community health center model. But when I say very supportive, I don't mean that they have a budget line that says community health centers will be funded. Okay, so what I do mean is that in principle, they recognize the value of the model and are in support of CHC development. But the tricky bit around the funding is that right now there are targets to create more urgent and primary care centers, so the UPCC model that Susan mentioned, and there are targets to create primary care networks, which is the regional planning entity that gets funded for FTEs to allocate for service delivery in a region. Sometimes they're allocated to community health centers, other times to other agencies or held within the PCN itself in the region for their service delivery. So there's work still to be done on actually getting what I would like to see, and that is targets for CHC development in the Ministry of Health budget. The care model, because it is broader than just primary care, and I don't say just primary care lightly, because that's an important aspect of care delivery, but the service model of a CHC is primary care plus, right? It's that wraparound allied health service, team-based care, and it is admittedly an expensive model. That said, the current focus of government is on attachment because there has been so much attention paid to 900,000 BC citizens not having access to a doctor or a nurse practitioner. And so that's attachment, right? So that's the primary government focus right now, is to get centers and services and docs offices and CHCs and UPCCs running so that the attachment gap can come down and more patients can have access and have a doctor or nurse practitioner to call their own. That's the primary focus of the government right now. The focus is not on the broad-based kind of team-based care that community health centers provide. So part of what we're working on is to do what we call going beyond attachment, because when you have team-based care and you have practitioners wrapping around a patient, you're keeping them out of the ER, like Christine talked about with her 335, ER visits not had because of her service delivery model. You're keeping them out of ER, which is expensive, and you're doing that preventative health care that also keeps them out of specialty care, because you can keep health, keep the patients healthier and away from needing ultimately specialist care. So the work that we're doing is to, when I talk about the value proposition of the CHC, and ensuring that we're going beyond just counting attachment, right? We're going beyond the recognition of the importance of the need for that holistic, all-centered patient care. And so that's the conversation we're having with government right now is, yep, okay, CHCs will come online and they are a bit more complicated because they're dealing with a complex patient who takes longer, and the attachment numbers are going to tick up more slowly than maybe the ministry would like because that's their current measure. But look at the other things. Look at the visits to a community health center and all the practitioners. Look at the kind of outreach CHCs do, the kind of health education that is done in community. Look at what mobile health services do to benefit the seniors or the immigrant and refugee population, to give them access to care that they would not normally get. So we're really working hard in this evaluation space to prove the model as being more than primary care and being extremely impactful in the system, that goes just beyond counting the attachment numbers, which is sort of the politically charged data metric at this point in time. So Paul, that is a really long answer to your really short question.
Well, just a quick follow-up to that. So I did mention to Ted that I felt that we need to redefine what attachment means. And that from my perspective, being attached to a place of care is much more important than being attached to an individual primary care provider. And I think that's one of the beauties of the CHC model, is that you walk in the door and you're attached to that place. And, you know, perhaps we need to redefine what attachment means rather than, you know, so again, so that the ministry can be motivated by attaching more people rather than less, right?
Yeah. And there is a move, absolutely, with Ted and his team. So Ted's the Assistant Deputy Minister of Primary Care at the Ministry of Health. So his team has absolutely recognized that attachment numbers alone, you know, patient to NP or patient to GP is an inadequate metric. And we are talking about patient attachment to a CHC site. So thank you for continuing to bring that message when you're in these conversations. Absolutely. Phoebe, who is next?
We have Larry next.
Thank you.
Yes, hello. Can you hear me?
Yes.
Apologies for my camera. I'm having finger trouble. I don't know what the issue is, but I must admit I am not familiar with your organization. This is my first exposure to it, and I'm very encouraged by what I'm hearing here today. I've been involved, I live in the Oceanside area, and have been involved in advocating for healthcare improvements for quite a number of years. And we finally were able to get an urgent care center in the community. And there was promise of a team-based primary care facility as part of that. That never materialized. The unattached patient numbers are growing phenomenally, and basically the community has very little faith in the health authority, or the ministry for that matter. They seem to be playing whack-a-mole with healthcare dollars rather than having any concerted plan. And you know, what you seem to have in place here is quite amazing. So my question to you is, how did this come about? And I'm assuming that you are totally separate from the ministry. You obviously work with them, but how did you get started?
So yeah, quick thing, so maybe we can see everybody's faces. Lisa, would you mind dropping the deck so that we have everybody's faces looking back at us? That would be great. So yeah, how do we get started? So I am 4 years old with this organization. The organization is older than I am, so it's 7 years old. But it started as most organizations do, with a bit of a grassroots push. So there are a number of community health centers in the province. In 2017, I think there were about 15 or 16 operating at that time. And they decided that they needed to have an association and a place to go to share their challenges and to maybe develop some advocacy strategies. So a number of the operating community health centers at that time created the not-for-profit, which was BCatch. And off the sides of their desk, they started to help each other and support communities and start some advocacy work around the CHC model. And one of the instrumental individuals, his name is Gray Schowler. Gray is a registered nurse here in Victoria, and he was instrumental in starting the association, as was the executive director of Mid-Maine Community Health Center and also the Community Health Center at Madeira Park in the Sechelt area. So those were three of the folks I know historically got together and started the association. Yeah, and so basically a need identified by a few of the community health centers that were operating at the time, who did what a lot of folks do, started something on the sides of their desk. Yeah.
So are these practitioners or are these community members?
Both. So Gray is a registered nurse. Irene was the executive director at Mid-Maine. She was a registered nurse, but she was also the leader of the CHC operations organization. And the gentleman from Madeira Park was a community member. He was a finance individual who was on the board of the Madeira Park CHC. So a little bit of both.
Yeah. Well, that's great, because I think, you know, the community is the one that's going to benefit, and without them being involved, you're doomed to failure. And I'm sort of involved on the periphery with the PCN here in the area, okay, and very disappointed with what that is promising to be. They're creating this advisory committee, but they really don't want any advice. You just, sit there and attend, and that's rankling a lot of feathers. So I think we need to find something along the lines of what you're doing. So thank you very much for this. Well, I'm most appreciative.
Thank you, Larry. Well, and one of the things that we're doing, also wearing our advocacy hat, is we're talking about PCN reform and the fact that the community voice by and large is missing. And so part of the agenda for PCN reform is to create these community advisory groups. And we're interested to know, are they working, right? When they exist, are they working? What does community think about it? And I know, working with Paul and his team at the BC Rural Health Network, I think collectively we're going to be keeping tabs and trying to make sure that the community voice has avenues that are very necessary, because our position is that, the community voice needs to be involved and easily find ways to talk about what is needed in healthcare for the individual communities. And if you want to get political, an election's coming up, and we've asked our CHC members to write letters to the candidates in their region to continue to build awareness of the CHC model, and to even offer tours of CHCs for the candidates if they want to have a look at operating CHCs and really learn and understand the model. And so we're willing to do whatever we can in terms of political advocacy as well, because healthcare is hard, right? It's hard, and it takes everybody. And there's a lot of groups that are involved, so it's complicated. And so these conversations have to happen in community for sure. And again, a really long answer to a short question.
Well, thank you very much. Keep up the good work.
Thanks, Larry.
And we have Jane next.
Well, good day, everybody. I'm coming
Ms.
to you
Jane.
It's Ms. Jane coming to you from Snuneymuxw territory, adjacent to Larry. Yeah, and one thing I find curious in Island Health as the health authority, I want to spend most of my time trying to get pointed in the right direction. Yes. But one thing I do notice is where we have some really strong, and Island Health has sort of underwritten this in many ways for a long time, community health or wellness networks. So for example, in the Cowichan, out on the West Coast, I was just in the West Coast, not the Alberni Clayoquot as a whole, but the Clayoquot piece of it. When I see those very functional places, they are very collective, and they do seem to have more success at, you know, anything associated with a community wellness network here in the island, like a PCN, like, you know, these various mechanisms. But then I notice wherever we don't have that strong collective voice and connection, it's an issue. So it's knowing that I have a health authority in my backyard who sees some success over here, and then they want that replicated over here, over here, over here, in all the different regions. Yet all the regions are different. Some have a bunch of islands, some have a bunch of, you know, logging roads that go into little remote places in the center, 3 different tribal groups, on and on and on. The one size fits all isn't doing it. And so shifting, yeah, I guess you're right. It's, you know, it's advocacy up the chain, you know, but it seems to me advocacy with health authorities as well, you know, into their senior folks, right? Not just to the ministry. And Susan's shaking her head. I'm not sure about what, but anyhow, I think she's next. I better lower my hand here.
Thanks, Jane. And, you know, historically, every health region, so every health authority used to have a community health network. The only one that is still in existence is the one on the islands. And I don't know what happened to the rest of them, because I did 5 or 6 years ago meet with a number of the CHNs, so community health networks. So I don't know what happened to them. Interesting.
Yeah. Interesting. Yeah, that's curious too. Thank you for that information, Valerie. Yeah.
You're welcome.
And we have Susan next.
I think one big thing that happened was that I missed out. I wasn't working as a nurse for a long period of time, so I wasn't keeping track. And my experience mostly was in Toronto, in Ontario. I trained at this hospital for sick children in the dark ages and so on. But bureaucrats that are in charge of, are in authority positions in BC Health. I don't know what all the official names for these things are, because they change every 10 or 12 years. None of them have a health medical background. They may have an MBA, and they are all about dollars and cents and so on. But I had a friend who worked for Vancouver Mental Health for a while, and she was just tearing her hair because it was about the 3rd time they had changed models. And so she said, our CEO, and they're called a CEO now, they're not called a supervisor or a director. We call her the log lady because her experience is in the logging, the lumber industry. She knows nothing about healthcare. So, but she's getting the big bucks. And the latest big bump of money that the BC government got, I believe it was $3.6 billion. Not $1 of that went to an actual healthcare practitioner. No nurse practitioners, no nurses, no doctors. It all went to administrative staff. They are bureaucratically top heavy, way, way top heavy. And that's why we see all these bizarre things. Oh, we know it's not working, but we can use this model and we can just plug it in all the way across the province. And that's what we do because it saves money. I'm just throwing that out there. I'm not using the right terminology, and I have no authority to say something like that. But I hear it. Like at the moment, I have a home support worker with me because I've recently had a hip replacement. And she's been working for 30 years doing home support. And she's super knowledgeable. And even they know it. That's what's wrong with the system, is it's top heavy with bureaucrats, not with medical people. I mean, in the old days, the hospitals each had a business department, and then they had a nursing supervisor. They had a chief of staff for the surgeons and so on. All of it they were medically trained people, and they had authority. They knew what they were talking about. But now they're delegating so much of that to these people who are not familiar with the medical system. I'm sure they're doing their best, but They're making a complete botch of it. And it's like trying the same thing over again and over again, like they say in AA. Just keep trying the same thing. And if it doesn't work, try it again. Try harder, try the same thing. And it's not working. Anyway, that's all I have to say. Sorry if I repeat myself. And it's not going to work as long as they keep that model. But the Greens are the only ones that I've heard speak about community health centers. And what do they call those people who are trained by the armed forces to help doctor assistants?
Physician assistants.
Physician assistants. I think BC is one of the only provinces that isn't using those people.
We're using them now.
How many? Two?
A few in a pilot project at
Yes,
Saanich
it's a
Peninsula
pilot
Hospital.
Yeah.
Thanks.
Oh,
Thank you, Susan. Yeah.
I'll shut up now.
Oh.
Oh dear.
Who's next on the
We
hit
have-
parade?
We have Catherine next and then
Hey,
Christine.
it's me, Val. I just want to do a very quick public announcement to let all of you know that we thank you. We have received about 16 questions when all of you registered, and we're not going to have time to go through any of the 16 questions. So we'll be answering them. Phoebe and I will just craft answers and getting back to you via emails. That's all I want to say. Thank you.
Oh. Thanks, Catherine.
Perfect. And then Zerguna, did you have a question? Your hand was raised. Oh, there it is. It's back. Perfect.
Should I speak? I just wanted to comment about the decisions about the healthcare system and should it be medical staff doing it or other stuff. I'm a trained medical doctor from abroad, and I don't think decisions about healthcare should be medical only. Why? Because social determinants of health makes up to 53% of health. And so the decisions about the healthcare system should be done in a team. It's social workers, community, and medical people, the people with medical backgrounds. That decision will create a system that will really help. Otherwise, it's really complicated to listen only to clinicians because clinicians talk only medical, and medicine is not the sole determinant for good health. Thank you.
Thank you, Zarguna. I appreciate that. And the complexity of the system is, it takes many hands and many voices, right, to actually design and deliver care. Appreciate that.
Okay, we'll go over to Christine and then Susan, back to you after that if you have another question.
Sounds good. Yeah, I just wanted to comment. It's very interesting seeing what's gone on across Canada. Quebec used to have a lot of community health centers. Now they're all run, all those community health centers were absorbed under the health authority type system in Quebec. Ontario has many community health centers and are very established. The costs of them and the populations, they're trying to understand all those pieces. I think BC has been really strategic in understanding where community health centers fit into the larger system. Cost-wise, they can be expensive depending on the population and what's going on. So I think that there's a lot of learning across the province. In regards to health authorities, we used to have regional health boards, and I get to talk with them tomorrow. Actually, we have a health board that sits underneath the Thompson Region district of our area, the TNRD, Nicolet region. And so there is a group of 27 primarily mayors and appointed officials that sit at that table who still have lots of conversations with our health authority, primarily around capital and funding that is asked for. I think 33% or 40% of their capital asks come from our area, and there's money that's transferred over. I think a part of the brilliance of community health centers is competition. And so these large organizations manage tremendous risk. I think where the cost is actually coming from is that health authorities, having 5 health authorities across the province with provincial funding and deep pockets, the risk and the legal fees and the managing that decision making and authority and the division of authority to risk manage. These organizations were set up to provide care, but they've become these huge risk management organizations also delivering care. And so tremendous amounts of money are going into these organizations because we have a public system and we haven't quite figured out how to do that really well. So there's community health centers, which I think are, STEPS was created to create competition and innovation and understanding and how could this be done in a different way. And so it's a great model in figuring those things out. I think the ministry is figuring out how do community health centers work? How do these primary care centers work? How do these urgent primary care centers work? And why are they working? And I think that that's part of the BCATCH story is that community health centers don't have deep pockets and we can't take on like that risk profile is very different. And so we can be very lean and you can be very nimble in the decision making at a community level. But I agree. The system is at a place where a tremendous amount of money is going in and not necessarily into the delivery of healthcare for a variety of reasons, including changes with WorkSafe BC and the requirement to accommodate people. So there's some big policy pieces that are really great for people, individually, that are putting tremendous amounts of pressure on different businesses and organizations. We actually don't have any family doctors or physicians that sit on our board of directors, and I am a business person, not a clinical or a medical person. I rely heavily on our medical people to lead that medical clinical workflow, all those pieces. They have autonomy and responsibility to their colleges and their licensing professionals, and we support them in figuring out those pieces. Our board and myself and our administrative team really focus on the business pieces and mitigating and ensuring that we have a structure that's efficient and effective and mitigating those risks to streamline. I hope that's helpful, but it is a very, very complex system, but I'm optimistic in the next 5 years, we're going to have a lot of data and we're going to be able to understand the BC health system in a way that we never have. And we're going to be able to health human resource in a way that is really, really cost effective because I'm 40 and I've got a long time to access these services and so do my kids. Anyways, thank you for having me.
Perfect. We'll go over to Paul.
So I just dropped into chat a research paper that we did with Jude Cornelson with the UBC Centre of Rural Health Research about community engagement and the real lack of engagement happening with rural BC. And that work, again, is leading into a second round of development on this study, which is we're now doing regional roundtables with community champions from around BC, looking at how to re-engage and looking at solutions to that gap and filling it. And as I've said to Val on many occasions, that if we had a broad policy on development of community health centres within rural BC, we wouldn't need to do the research and we wouldn't need to fill the gap because there wouldn't be one. And so I think that, the community engagement piece is really key. And I think the community health centre, in the true sense of the word, really does provide that benefit. And earlier on in the conversation, when there was talk to how to reach seniors populations and the model that is being followed under Umbrella, and I was going to ask Zarghuna if you'd like to speak a little bit to your desire to expand the model into other areas of the province. And I see, again, part of our problem with recruitment and retention and retaining people in underserved communities, which also have limited provisions for people to want to be there. Where if we have a mobile CHC clinic going from a central location out to communities that are in proximity to it, seems to be a very natural fit to serving our retention and recruitment problem. So I don't know if Zarghuna is still with us, but if she is, if she would like to speak to her desire to expand what's happening with Umbrella.
Well, thank you, Paul. As you know, Umbrella Mobile Clinic did its first outreach to the rural areas. And the reason to that was because we are aware that increasingly there are more newcomers being settled in rural areas, and that's due to the high costs in Vancouver Lower Mainland, along with farm workers who are working on the farms over there. Umbrella definitely will be interested, as Kwao mentioned in his presentation, to support other stakeholders in rural areas to either they create mobile clinics. And someone said that it could be implemented to different communities, not only like senior communities or those who have mobility issues, or Umbrella could also expand mobile clinic to other cities, depending on the funding availability. So we are open to both, and we are known to being a good collaborator organization in the Lower Mainland by other stakeholders, and Val is. Thank you.
Am I up next, Phoebe? Oh, you're on mute. I'm gonna go. Okay.
Yeah, go.
Yeah. I scrolled through the chat as well, and if John Grogan is still on the line, John, you were asking what is the Union of BC Municipalities' position on community health centers or their awareness, and Paul had answered, indicating that Catherine and I had done a presentation last year at the UBCM conference last September in Vancouver. And I think about 300 municipalities attended this presentation. And we also had a few CHC leaders on a panel to do some Q&A. And I wanted to highlight that there's a new program of support for municipalities who are interested in getting involved in healthcare planning, but also recruitment and retention of healthcare providers. And it's called a Playbook, and it's just been launched by the Saunders Family Foundation and the Thrive organization. It's being supported by Ministry of Health, and the Playbook talks about how municipalities can get involved in healthcare conversations and planning. And a couple of examples of what they're suggesting is that if a municipality wants to get involved and support recruitment and retention of health practitioners and opening of new kinds of clinics and things like that, that they take a look at working with developers who want to build condo buildings or malls in their community. And they say to those developers, yep, come on in. Municipality is interested in talking with you about some more development. And when you do develop, we would like you to develop a clinic so that we can open a CHC in our community. Or we would like you, if you're a condo developer, to develop 2 condos where we can house healthcare practitioners or allied health team members or whomever to provide healthcare in our community, and who maybe can't afford to come here, or who don't have a space to live because we have a low rental rate. So that's just one suggestion of what this playbook is recommending to municipalities, communities, and townships that want to get involved in healthcare planning and recruitment and retention. And so and I think Paul popped the link to the playbook in the chat, and BC Rural Health Network is a great supporter of the Saunders Family Foundation, as is BCATCH, on this initiative to get municipalities more involved in what needs to be done to support healthcare service delivery in their municipalities. And so it's just a thought, right, about tools that are popping up to support the conversation and community engagement in health planning and recruitment and retention. So there you go. Yep, you're welcome, John. Thank you, Phoebe.
Perfect. We have Jane next, and then we'll go to Bob after that.
This is more of a comment than anything else. I recently, was spending time at Hulit Lelam. Hulit Lelam is the Snuneymuxw Nation Health Center here in located here close to me in Nanaimo. And, you know, and I do some work with First Nations Health Authority, you know, wherever possible. And, you know, we have this interesting situation in BC with 205 First Nations, or somewhere in counting, or might be a little lower, a little higher by now. And 55 of them are here on Vancouver Island. And what I am observing, you know, is we do wherever possible silo, but those same health centers that serve, you know, need to triage people into, for example, NRGH, Nanaimo Regional General Hospital, which happens to be one of the most unfriendly places I've ever been for either queer, trans, or Indigenous people. I hope nobody heard me say that over here. I mean, that's not a blanket statement, but I just know of a number of people who come to me and say, oh, you'll never believe what just happened to me. So, you know, it seems to be the community health center is so important in some form where, you know, at least you've got an ally, somebody who's going to help you with the system navigation part of it, which is such a key part. It's so, I mean, you know, I know I've sat beside people at NRGH, you know, triaging between them and a surgeon who maybe lacks a few skills in terms of acceptance of diverse populations, or whatever you want to call it. So I just wanted to bring that up as just yet one more thing for us to think about as we think about, you know, yet another about how to make access to healthcare much friendlier and more supportive for more marginalized people. Couldn't resist. I'll try to lower my hand.
Thank you, Jane. And we'll go to Bob next.
Thanks, Phoebe. Yeah, a couple of questions. One for Umbrella. Here in the last 3 years, we've had quite a bit of industry, like the pipeline, where we've had huge camps. You know, 700-800 people in these camps. Is that something that Umbrella would be capable of managing or looking after? That's question number one. And then question number two is for Val and Catherine, because they're quite aware of what we're going through. I've talked to them, and I still have a problem how we're going to get to a CHC model. And I guess the question is, how do we get to a hybrid? So maybe we'll start with Umbrella, if you could answer that question about the camps and whatnot.
I think the first one should go to Val, because they can talk about CHC, and then mobile clinic will come after that. Do you agree, Bob?
I'm okay either way, Saguna. So yeah, I'll give it a go. Bob, what do you mean by a hybrid? What are you thinking?
Well, you know, we have a clinic here now, which you're aware of, and you know, for us to set up a CHC just doesn't make sense. That means that we would have to set up and hire doctors when we have, theoretically, we have sufficient number of doctors that work out of the clinic and that are hired on contract by Northern Health. But what we do need is public collaboration. So it would be kind of a hybrid, I guess, community health council, or whatever you want to call it, I guess.
So I mean, I think your potential avenue is with the community then, because if you've got care gaps still, and you have your clinic, and so you know, creating a CHC is, you know, duplication and wouldn't really solve the problem, because you have a functioning clinic there, but you have needs that are unmet. I know you have conversations with the health authority, so that is their job. whether we like it or not. And B, I'm not sure where Catherine and I would be in the mix here with you.
I know it's a difficult.
Yeah, okay. So I'm
we haven't
struggling
had
in a ditch. Yeah.
we haven't had the conversations with Northern Health yet either.
Okay.
After they promised to meet back in January, we kind of anticipated something by now.
Okay.
I have sent a questioning one, but I mean, I guess we'll have to work through that one as we go along. But my other question was for umbrella, because, with these camps, it puts a real strain on the local clinic. I mean, we were looking at 5-6 weeks for me to get an appointment to see my doctor because they were so backed up. Where, if we would have had something like umbrella that could have come in and, with a mobile clinic and look after the different camps. I mean, there was what, 6 or 7 camps all along in the north. And obviously they would have put an extreme pressure on the local health clinics.
I think to answer your question, Bob, umbrella itself has a specific population that we work with, and that's the eligibility criteria that people should have either culture or language or both barriers in accessing healthcare system in BC. But in terms of serving, having a mobile clinic to go and serve populations where they are at, physically at, that's possible if, even your clinic that you have may have a branch that's mobile and serve those camps.
And I think too, Bob, just to chime in, I'm familiar with, in the past, industry would create a mobile clinic for its workers on their industry site. So I think this is something that the particular industry organization should or could think to do, is provide a mobile clinic on site if they were so inclined, because that was an effective model in the past.
I guess something for future generations when they have more camps.
Okay. Thanks, Bob. Paul, over to you.
Yeah, I just wanted to say that I wasn't suggesting that Umbrella was the group that's going to fill all these gaps. It's the model of care, and that mobile CHC benefit that I see as being the benefit too. So I don't want Zarguna's email to light up with everybody's request for her to provide services to their community. And from a health authority engagement perspective, we are meeting with the executive team quarterly with Interior Health, and we've now started that same arrangement with Northern Health and Chiro-Panessa and their team. So that again is challenged by the fact that it needs to have the push from the province in order for them to look at alternative models, and for them to pilot new models within the health authority really needs to be driven from the provincial level. So our advocacy is at all levels, but we see the need and the push to come from the Ministry of Health in order to start seeing new models being established and experimenting with pilot models within community. And as Jane said, about the only health authority that we see as having effective health networks within their health authority is the island. And they really do a much better job at community engagement than others. And that's not to say that others cannot, but we need to push, I think, at the health authority level to have more significant engagement models and mechanisms brought back in. And also, just as a quick point, the health boards of the past were not effective. They were also challenged, and that when they were in play, that people want to bring back old systems. I think we have to reinvent systems for the future, and not look at how we can duplicate systems from the past, because they just don't fit in context to life as we know it today. So I shall leave it there.
Okay. Thanks, Paul. Over to Sue.
Thank you. Thank you, Paul. It's great to see all of the familiar faces today. And when we talk about the mobile services, I think some of you know Pam Beach, but we certainly looked at that and thought of it for the shoe swap area because of how all the communities are so far apart. And healthcare is essentially in Salmon Arm and some in Chase. And so, but I do think that the mobile model could be, and especially in the northern communities, could be a really successful model, and one that I think we can advocate for. And having the model that's in place right now and working is great. I'm certainly going to be giving you a call. I think it's a great example that we can strive for. Thank you.
All right.
Thank you. That's all the questions we have right now with hands up.
Awesome. Oh, Catherine's posting some resources in the chat. And certainly we could point you to the BCatch website. Lots of resources there, www.bcatch.org. And you've got Christine, Zarguna, Catherine, and my contact info, or failing that, Paul and Phoebe directing traffic. Awesome. Okay, well, we've moved into the silent aspect of the conversation. And so looks like we are done for today. But again, thank you, Zarguna, Christine, and Cow for joining us to answer some questions and really shed some light on the CHC model in operations and talk a little bit about challenges. We totally appreciate it. Paul and Phoebe, our gratitude is to you for hosting this for us on our behalf so that we can continue to raise awareness of the CHC model and the different kinds of things that we are doing and other things we can collectively do. So thanks a bunch, and thanks everybody.
Awesome.
Thank you, Val.
So much.
Thank you, everyone. Been a
Bye,
pleasure.
everyone.
Thank you. Have a good afternoon.
Thank you.
Have a good afternoon.
Thank you.